Originally released in April 2020, this re-released episode of the Hope with Answers, Living with Lung Cancer podcast explores the life-saving impact of early detection. Two-time lung cancer survivor and LCFA co-founder David Sturges shares how early testing gave him a second chance at life. Joining him are Dr. Denise Aberle, a leading thoracic radiologist, who explains how low-dose CT scans can detect lung cancer in its most treatable stages, and Dr. Kellie Smith, who offers a look ahead at how new post-surgical treatments may help reduce recurrence.
One of the things we love so much about working with the incredible people on the LCFA Speakers Bureau is that we get to know so many statistical outliers. That means the people living with lung cancer years, even decades after diagnosis.
And that is certainly the case with our next guest. He was diagnosed with lung cancer in 2002 quite by accident. It turned out to be a very lucky catch for David and also for LCFA itself. But we are getting ahead of the story.
That's right. Let's hear David tell the story himself.
David Sturges, thank you so much for joining us today. We appreciate it.
Well, thank you for asking me. I'm delighted to be here.
So your story is somewhat unusual. You're a 14-year survivor. Is it 14? Am I wrong?
Well, I'm happy to tell you that you are wrong, Sarah, that it is actually 18 years since my first diagnosis. You are correct. I had a more recent diagnosis 3 or 4 years ago, but I like to take it all the way back because it's 18 total.
18 years, that is absolutely astounding. And I think that just shows the change in lung cancer treatment and diagnosis. And we're going to get into that. But David, you have an unusual story in how your lung cancer was first discovered. What is that story?
You are correct. It is unusual, and I am profoundly lucky because my diagnosis was by luck. I was being seen, for a routine cardiac review, and they suggested that I have a high-speed CAT scan, which is a way of identifying the buildup of calcium, what have you, in the bloodstream. And I had that, and it came back. Basically, the numbers were normal or within normal range, which I felt very good about. And I set the report down. It came directly to my house, was not given to me by my doctor. And later I thought, well, I'm going to read about this more. And literally, there was a footnote on this report that said, we've identified a nodule on the lower right lobe of the patient's lung. And this may be something that has been there and is being watched, or it might be something that has not been identified before. And if so, we suggest that he seek further examination, which I did. I called my cardiologist, and he said, well, let's get you in and let's do a biopsy.
David, can I interrupt you for just 1 second? As I remember, you were super healthy, super athletic, and had just jumped out of a plane. Is that right?
And climbed Kilimanjaro?
The plane came later after surgery, but prior to my diagnosis, about a year before, I had run the San Diego Rock and Roll Marathon, and maybe a year and a half before, I and a friend had climbed Mount Kilimanjaro. So I wasn't, if I can say it, I hope, not the typical camel straight smoker who was wheezing and surprise. It was something that I never would have thought would happen to me, even though I had been a smoker.
Wow.
So the diagnosis itself must have come out of the blue.
It did. It was an absolute shock. I remember during the course of the biopsy, and the doctor said to me, David, there are live cells here. And I was in a daze, and I said, what do you mean, live cells? He said, it means it's malignant. It means you have lung cancer. And that was it. He said, you're going to have to contact your cardiologist who will set you up with others. But that that was what he told me, and he was done for the day, which was another thing. I was left hanging in limbo
Wow.
with this diagnosis, really not knowing, not clearly not even having a clue. Well, what is the treatment? And in my mind's eye, at that point in my life, and also all of the scientific advancements in cancer treatments that I had read about for other cancers, I thought, well, this will be kind of an easy road. It'll be easy, quick, and I will be done with it. I found out something quite different as I went forward and was told the only treatment therapy I had available to me was surgery, that there was no other therapy available for an individual in my situation. And quite frankly, that is still the situation for an early stage lung cancer diagnosis, which in many respects is a good thing too, that they feel that surgery is the best approach in that case to hopefully then prevent a recurrence.
And you were diagnosed again very early, a couple of years ago, a handful of years ago, and you call that diagnosis plain dumb luck as well, like the first one. But things have changed so much in between your first diagnosis and your second diagnosis. Can you talk about what has changed in part due to some of the work that you've done in the interim?
I think that for many lung cancer patients, maybe not me particularly, many things have changed in terms of a diagnosis and the possibility of early diagnoses, which we have developed. The National Lung Cancer Screening Trial is a prime example, which identified finally and said, yes, high-speed CAT scans of the lung will identify lung cancers quicker than an X-ray. An X-ray prior to that time was the standard of treatment. So yes, it was a very exciting from a point of view of, even though I was getting CAT scans, this was, and everything pointed to, this is the correct treatment that you should, or observation that you should be having. And it did. It once again identified another nodule at a very early stage. And again, the treatment was surgery. But I think the other part of it, too, of that equation is that even though the type of surgery I had the second time, which is called VATS, video-assisted thoracic surgery, had been around when I first had surgery, it has been so developed in the meantime. The amount of time that I was in the hospital was reduced. I have two small, maybe 1-inch scars where they went in to remove that malignancy, as opposed to my first surgery where I have a very, very long and very vivid scar yet, where they went in and literally opened my chest and went in through my ribs to access the lung.
What a difference from the first surgery to the second, and from the first diagnosis to the second.
Yes, and and the time in the hospital was greatly reduced, and I was home. I was walking. I've told the story. I think I had been out of surgery and home a total of maybe 8 days, and I was going out for a walk, and my surgeon called me saying, I'm checking to see how you're doing. And I said, I'm on my way for a walk. She said, perfect. It's the way it should be.
That is the way it should be. But one of the things that is not the way it should be is how much money goes into lung cancer research, about how much research is actually being done based on the number of lives that could be saved with lung cancer. And you're one of the leaders in lung cancer advocacy, and you've helped create Lung Cancer Foundation of America. I'd love to know how that came about and what motivated you and what keeps you going.
What keeps me going, I'll start with the latter question first, is the fact that I and everybody else at LCFA think that we are helping not only those individuals diagnosed with lung cancer, but their families as well, by virtue of the phenomenal research that we are sponsoring through the foundation. And when we started, that was what we recognized from our point of view that we felt was missing, is an organization that was solely intent upon and directed its attentions to research. And this isn't taking away from any other organization. They do fabulous work, but we figured we need this singular approach, and we hope by way of that singular approach, we would provide a phenomenal benefit to lung cancer patients and their families. And I think that that is working. And it also was helping to step in to help amp up the funding that is necessary and called for lung cancer research, but is I shouldn't say wholly lacking, but is very, very diminished when you compare it to research monies that are applied towards other cancers. And in that vein and against that backdrop, we have to continually remember and focus on the fact that lung cancer does remain the biggest cancer death, not only in the United States, but in the world for both men and women.
And this all started with a call coming from out of the blue. Is that right?
It did. It was my then treating oncologist who was at UCLA, and he was connected and one of the researchers on the NIH, National Institute of Health, SPORE program. And SPORE is, I think, an awful acronym, but nonetheless, it means specialized programs of research excellence. And he asked myself, and I found out later in another separate telephone call to Kim Norris, one of the co-founders, would you be interested in being a patient advocate for our SPORE at UCLA? And quite frankly, I didn't even hesitate. I said yes, and then asked, what does it involve and what does it entail? And he said, just about anything you want. And Kim and I took it from there and met Lori Monroe, who was the third co-founder of LCFA. And at that point, Lori was already a patient advocate for a Vanderbilt SPORE. So we had a somewhat common background in terms of what we felt was important and necessary for the lung cancer community, though we were coming at it from slightly different approaches. Our first venture out was we were going to crack Capitol Hill and we were going to get lots of government money. We had a wonderful reception, and then all the times we went to Capitol Hill, but the money, the funding was not there in terms of anything greater than that was already there. And we said, we think we can do it better in terms of forming our own nonprofit, which we did. And as I say, with the singular focus of funding the innovative lung cancer research.
And your work with NIH has continued. Can you tell me a little bit more about that?
Yes, I've had two go-rounds, if you will, with NIH. I was the patient advocate on the National Lung Cancer Screening Trial. So coming from my point of view of my lung cancer having been diagnosed by way of a CAT scan early on, I found it particularly interesting and particularly important research. And now I sit on the Department of Defense Lung Cancer Research Program. The Department of Defense provides funding for research for basically all cancers, leukemia, breast cancer, so on and so forth. But I sit on the lung cancer one, not surprisingly, and it too is fascinating and interesting, and particularly from the point of view, it kind of mimics or mirrors what we do at LCFA. Its singular focus is, here's the research and what research is out there that's going to crack the code with respect to possibly a cure, but also new treatment methods that may help turn lung cancer into just another illness, if you will, that has to be watched.
And part of what we're doing in this podcast is talking to other lung cancer advocates who have similar stories to yours, who have gotten into advocacy on behalf of more research funding and clinical trials and how clinical trials treat patients. And we're also talking to Denise Aberle, who is a friend of yours and also worked on your case as well.
Yes, absolutely. And it was Denise Aberle that invited me to be on the National Lung Cancer Screening Trial as a patient advocate. And that's how I became acquainted with her. And she has done phenomenal research and is extremely active in terms of the early diagnosis of lung cancer. And added to that, her ability to explain the disease, what is out there for treatment, what might happen, what might not happen in terms of the evolution of treatment modalities better than anyone I know. And beyond being a personal friend, I mean, anybody, any advocate's friend, from the point of view of what she can give to an advocate in terms of lung cancer research and treatment for lung cancer.
We should probably say it's Dr. Denise Aberle.
Yes, we should.
Yes.
And she is probably one of the leading lung cancer researchers and a radiologist at UCLA.
UCLA.
Yeah. So I just wanted to make sure, because we all know her so well.
I know we get to call her Denise Aberle, but it is Dr.
It
Aberle.
is Dr. Denise.
Yes. Say it with a certain amount of reverence.
Absolutely. Yes. Absolutely.
Well, David, thank you so much for sharing your story. It's just really astounding to be talking to someone who has 18 years out from diagnosis and who has done as much as you have to bring attention to lung cancer and the need for funding and the need for research.
If I could say one more thing in terms of becoming a lung cancer advocate, I've thought about it many times, and I can repeat for you how it happened. But I can very honestly say, and have said it to many people, even if I had never been diagnosed with lung cancer, if someone had come to me, let's say Kim Norris, you guys, and said, this is the background, this is what's happening, this is what isn't happening, this is why we need help, I think I can honestly say I would have still jumped into the fray. I think it's that important.
It is that important, but it also says so much about you, and we're just honored to have you. And I think all of us count ourselves lucky that there are people like you out there who see a need and fill it and do everything possible to make life better. So thank you for that.
Thank you very much, and thank you for what the two of you are doing.
Well, we're having fun doing it.
We are. So. We have a good time.
That's the important part.
We hope you're enjoying the LCFA Hope with Answers Living with Lung Cancer podcast. It's produced as part of our nonprofit mission, the support and expansion of lung cancer research accomplished by raising funds that serve to increase the public's awareness of lung cancer status as the leading cause of cancer death, inform and educate lung cancer patients in their lung cancer journey, and fund innovative lung cancer research. I have had the pleasure of working with Dr. Denise Aberle a number of times, and she's a great friend of LCFA's and a tireless advocate for early diagnosis and screening for lung cancer. She's a radiologist specializing in lung cancer at UCLA's Cancer Center, and she was on the team that developed the guidelines for who should be screened.
And this is something I love about the Hope with Answers Living with Lung Cancer podcast. We're talking with some of the top doctors around the country and sometimes around the world. And it's amazing to get this kind of incredible access. Oftentimes, like in this interview with Dr. Aberle, we're grabbing 15 minutes with them in between their dozens of appointments and meetings and a really, really busy day. So you're going to hear Dr. Aberle's very busy computer pinging her with messages and lots of activities. And it really gives you the sense of how hard these doctors are working in the fight against lung cancer.
Oh, and by the way, Dr. Aberle references a set of guidelines for who should be screened for lung cancer. You can find those guidelines in an easy-to-use calculator on LCFA's website in the About Lung Cancer tab where it says detection. That's kind of a lot. So you're going to go to the website, About Lung Cancer, and then hit detection. We'll put a link to that tab in the story notes of this podcast. But let's jump right into the conversation with Dr. Aberle, who's been specializing in lung cancer for about 25 years.
I was intimately involved with the one major screening trial that looked at the benefits of low-dose computed tomography or low-dose CT screening for patients who were at risk of lung cancer based on age or smoking. After the results of that trial were published, I've been involved in the national scene to try to help with the implementation of screening, to help with guidelines for how to interpret screens, and for developing the database into which screening exams are submitted to the Centers for Medicaid and Medicare Services in order to be considered for reimbursement.
So, from your perspective, one of the things that we just talked about at the LCFA patient advocate meeting last weekend was how quickly and how hugely things have changed in the treatment, the diagnosis and treatment of lung cancer, really in the past maybe 5 to 7 years. But given your perspective, how have things changed in the time that you've been specializing in lung cancer?
So lung cancer is really a continuum. I tend to work on the early side, meaning the early detection of lung cancer. But there's also the later side in patients who have established lung cancer or may have advanced disease. And there have really been major advances across the continuum of lung cancer. In the area of early detection, and by that I mean patients who are typically pre-symptomatic. They do not have signs or symptoms of lung cancer, but their cancers may be caught early. We like to think of early detection as also early stage, but that is not always the case. But in the early stages of lung cancer, probably the major benefit that we've seen over the last couple of decades is the fact that we now have a screening test for early lung cancer detection, and that is low-dose computed tomography. A couple of trials, one in the United States and one in Europe, have both confirmed that the use of CT for screening reduces the mortality of lung cancer by at least 20%, and in some instances, much more than that. So that means that we have the potential to identify a cancer before someone becomes symptomatic and to cure it or to treat it with intent to cure. That's a major advance because it means that more patients are being diagnosed in the earlier stages when they have the potential for long-term cure. On the advanced side, in patients who have established lung cancer and may have metastatic disease or more significant regional disease in the chest, we also now have a variety of therapies that can be used to prolong life. And many of these are what we call targeted therapies. They are therapies that were developed to address one particular gene mutation that a patient may have, and they allow that tumor to be held in check. There are times when resistance may develop and the therapy no longer works, but we have additional therapies that may be effective. And these therapies are not what we call the classical cytotoxic therapies, meaning that they kill all cells. They're really directed to the tumor. Although they have side effects, the side effects are generally less than in patients who are receiving traditional chemotherapy. And then finally, the newest thing in our inventory to manage lung cancer are immunotherapies, in which we're able to give drugs that stimulate the immune system to recognize a lung cancer as foreign and to attack it. And I think across this continuum, we're seeing substantial improvements in the way we diagnose, treat, and cure lung cancer.
So I want to step back just a little bit. When you are talking about CT scans to diagnose early stage lung cancer, this is something that David talked about. He was
his lung cancer was found on a scan for a totally unrelated thing. It was a cardiac issue. So when you are talking about asymptomatic people, people who are showing no symptoms, how would they access a CT scan? I mean, is it really by luck?
Well, interesting that you suggest that. Prior to screening, most of the lung cancers that were detected in patients who had no signs or symptoms were in fact incidental findings, with the scan having been acquired for another purpose. Now that we have low radiation dose CT screening, we're able now to identify eligible patients who are at higher risk for lung cancer based on age and smoking history, and to offer them screening, which currently in the United States, if you're eligible, third-party payers must cover the cost of the screening exam, as does Medicare.
So that is for folks who fall into those screening guidelines.
Yes.
But it sounds like still, and I'm thinking of the number of members that we have on the Speakers Bureau who did not fit that criteria and were not diagnosed until stage 3 or stage 4. What can you talk about the benefit to being diagnosed earlier? You mentioned a couple minutes ago that early diagnosis and early stage are not the same thing.
Correct. We would love to think that it could be, but even in the setting of screening, not all cancers that are detected, even in patients who lack signs or symptoms, will be early stage. They may be more advanced stage. What screening does is shift the stage across a population to earlier stages that are more amenable to cure. But unfortunately, not everyone who undergoes screening and is diagnosed with a lung cancer will have an early stage lung cancer.
And in early stage, you're talking about a couple of different options. I mean, you've mentioned targeted therapies for a specific biomarker and immunotherapy, which we're going to get into in the next part of this podcast, one particular study that is happening. But in earlier stages, there's also the possibility of a surgical approach. Isn't that correct?
Absolutely. In fact, most immunotherapies and targeted therapies are applied to patients with established cancer that may not be locally resectable. There are clinical trials looking at the benefits, particularly of immunotherapy, prior to surgical resection. But far and away, in patients with early stage lung cancer, what that really means is that the tumor is localized, hopefully to the primary lesion within the lung, and less so even to regional lymph nodes. So it's a very localized disease. Those patients are optimally managed with surgical resection. There are other ways to locally manage early stage lung cancer. You can do radiotherapy, in which you target the primary mass with radiation therapy. There are also ways in which you can ablate the lesion percutaneously using heat or thermal methods. For example, radiofrequency ablation, microwave ablation, and cryoablation. And there are different times or different reasons why you might use one over the other. Those are usually done by an interventional thoracic radiologist, and an instrument is passed from the skin into the lesion to ablate the lesion. With radiation therapy, you typically are just receiving very high dose radiation to a very restricted area. But those are all ways in which the local cancers can be managed or treated for potential cure.
Sure. And just to make sure that that I'm understanding everything, an ablation is where you are actually destroying that tumor tissue. Is that correct?
Exactly right. A probe goes into the mass and heat or cold are applied, which destroys those cells, leaves a residual mass, but destroys the cancer cells themselves.
Okay. So this is kind of a question from the perspective of someone who is asymptomatic. What should someone who's worried about the possibility of having lung cancer say? What should they go talk to their doctor about to see if they're eligible for a CT scan? How do you bring that up with your doctor?
Okay, so first of all, as a matter of health policy in the United States right now, there are well-defined eligibility criteria for screening. You must be between the ages of 55 to 77 or up to 80 if you have private insurance. You must have had a minimum moderate degree or extent of smoking. And if you are a former smoker, you must have quit within 15 years. Those criteria, there's nothing magic about them. They were the criteria that were originally used in the United States National Lung Screening Trial that I was associated with. Those criteria were designed based on kind of epidemiology to identify those people at highest risk of lung cancer. But I must say, they were never intended to be implemented for public policy decisions. Right now, because the NLST was at that time the only trial, those eligibility criteria for this randomized clinical trial were adopted as public policy. The United States Preventive Services Task Force is currently reevaluating the data to determine whether or not different decisions about eligibility should be entertained. But right now, you really can only get a lung cancer screen that is covered by your insurance or Medicare if you satisfy those eligibility criteria. Mm-hmm. So what about the patients who have a lesser intensity of smoking or who quit more than 15 years ago? Those patients are technically not eligible, and depending upon their insurance, they may or may not be reimbursed for their screen, which means that they would have to pay out of pocket. That's a decision that that person must make. What about the never smoker? We've looked at never smokers and the possibility of screening them, and it's technically really not feasible from a national economic perspective. Moreover, it would subject people to, although low dose, still typically unnecessary radiation, which we don't want to do. So we don't have a good answer for individuals who are never smokers, but we do know that there are a number of other risk factors that influence one's risk of lung cancer. One of them is family history. If you have a family history of lung cancer, particularly in your immediate family, but also in your more extended family, you are at higher risk of developing lung cancer. If you are exposed to certain known carcinogens, for example, radon, which is a natural radioactive gas that occurs within the earth, the ground. Some areas of the United States have more radon than other areas, but known moderate radon exposure will make you predisposed to lung cancer. If you have underlying chronic obstructive lung disease, that is an additional risk factor. And it would appear that some racial groups are at higher risk even if they smoke less. And those are in particular African American men. So in individuals who are afraid that they may be at higher risk of lung cancer because of risk factors other than smoking, they can address this with their primary care physician or their pulmonologist and make a decision about whether or not screening is right for them, understanding that they may have to pay for that screening exam.
And this is really part of the story that we hear from so many folks on the LCFA Speakers Bureau is there's a certain amount of self-advocacy that you need to be prepared to, embark on if you are looking for a diagnosis. And, I can count on two hands the number of stories of misdiagnosis that we have with, in particular, young non-smoking female lung cancer patients, but really kind of everyone. So I think it's important for patients to hear the message that sometimes you just have to be dogged in your pursuit of the accurate diagnosis.
Absolutely. Absolutely. You are exactly right. And I think that the incidence of lung cancer in never smokers, in people who have never smoked a cigarette, is increasing for reasons that we don't understand. We don't know if it's pollution or something that is within the atmosphere. But definitely this is on the rise over the last 10 years or so, and we desperately need ways to identify those patients who are at risk, even absent tobacco smoke.
Mm-hmm. And you have talked before about some new potential ways to diagnose lung cancer. And I understand that not all of these are sort of being used currently, but what are some of the things coming down the pike, hopefully? Potential new tools like a liquid biopsy, which is just a bit of blood, like a blood test. What are the things coming down the pike, hopefully, that will make diagnosis easier?
Well, so currently liquid biopsy is a reality, but it's more of a reality in the established or advanced lung cancer setting. And specifically, patients who have a single driver gene mutation, which means the mutation that is driving that lung cancer to continue to proliferate, will undergo targeted therapies. At some point, we have to begin looking for additional mutations that may cause the tumor to become resistant to the targeted therapies. So even now, we're doing blood tests in patients who are put on certain targeted therapies to look for additional mutations that we now recognize lead to resistance. And we do that through a blood test, and it is relatively accurate. We're heading in the same direction in the early setting of lung cancer, and we use a variety of different specimens. They can be blood specimens, they can be saliva, they can be sputum that you cough up from the lungs, they can even be brushings from inside the nostrils. So a variety of different readily accessible biospecimens are being analyzed, and we're looking at patterns of gene mutations. So there are a number of different ways to look for evidence of risk factors molecularly that would cause lung cancer. Very few of them have made it to the commercial stage at this point, but I think that's just a matter of time. And I think once that happens, then we're talking about a new era in being able to identify smokers or non-smokers who may have or be at risk of lung cancer.
That would really be an amazing step forward. So now it sounds like, if I'm hearing you correctly, that these additional diagnosis methods would take us out of the kind of closed loop of who's eligible for screening, and into something that's more accessible for more patients, potentially identifying folks who do not fit those high risk factors, and identifying them earlier.
Yeah, I think that's one of the hopes. I think we have a ways to go yet, but that's certainly a direction that we would like to go. Well, I think it's just important to know that there are ways to detect lung cancer when it's localized in its earlier stages, that if you are a current or former smoker, you should discuss that with your primary care physician. If you are a never smoker, but you've had family members or certain exposures to respiratory carcinogens, that might be worth a conversation with your primary care physician also. And also to understand that even though not all screen-detected lung cancers are early stage, early stage will dominate screen-detected lung cancers, and even patients with established or advanced lung cancers can now look forward to treatments that were not even here 15 years ago.
What an amazing set of information you've given us. I really, really appreciate it. And Dr. Aberle, I really appreciate the time that you've taken today. I know your schedule is just absolutely chock full from dusk to dawn, so we appreciate the time.
My pleasure.
Isn't that an amazing thing to hear? The idea that we could be looking at completely new, much more advanced ways to diagnose and treat lung cancer in the near future.
Oh my gosh, yes. It's one of the reasons we are so excited to work on the Hope with Answers Living with Lung Cancer podcast. And coming up next, one of our favorite people.
She really is. LCFA young investigator Kellie Smith talks about research she's working on that may make surgically treating lung cancer easier and more effective. Want more with Hope with Answers? Visit us online at lcfamerica.org, where you can find out more information about the latest in lung cancer research, new treatments, and more. You can also join the conversation with LCFA on Facebook, Twitter, and Instagram. You might not know this, but Lung Cancer Foundation of America's mission is to fund early-stage research, the kind of smaller-scale studies that can lead to much larger grants, because lung cancer is really underfunded.
Incredibly underfunded, especially at the federal level. And that's really the front line of lung cancer research, getting enough promising data to go after bigger grants for very expensive trials, clinical trials, and larger studies that can lead to better treatments or diagnoses.
And one person on the front lines of research is Dr. Kellie Smith of Johns Hopkins, an LCFA young investigator, and she just wrapped up a grant that looks at the benefits of a particular type of chemotherapy before surgery.
In the first LCFA grant that I was fortunate enough to be awarded, we were already planning to do a clinical trial of neoadjuvant anti-PD-1 in resectable non-small cell lung cancer.
And I wonder, I'm so sorry to interrupt you, but I wonder if you could help us walk through all of those terms really quickly.
Sure. So neoadjuvant treatment is when there's a therapy given, traditionally chemotherapy, prior to patients undergoing surgery. So this is in patients who are eligible for surgery, so earlier stage disease, not metastatic. And traditionally it's chemotherapy that they're given, and the goal of that is to shrink the tumor prior to them going to surgery, so it makes the job of getting all the tumor out a little bit easier. And the idea behind switching up that treatment regimen is that immunotherapy, specifically anti-PD-1, has shown impressive results in patients with metastatic disease. So we thought that giving immunotherapy in the neoadjuvant setting might not only help to reduce the tumor prior to surgery, but might also help prevent relapse in patients. And as you know, 50 to 70% of patients who undergo surgery for lung cancer will eventually relapse and die of the disease. So we really want to prevent that relapse. So we performed the first ever clinical trial of neoadjuvant checkpoint blockade in resectable non-small cell lung cancer. And aside from the impressive clinical findings, there was a 45% major pathologic response rate, which is amazing. Aside from that, we were able to do a lot of scientific correlative studies on the specimens that we obtained from patients who are enrolled to this clinical trial due to the funding that I received from LCFA. And several papers have been published based on the work from LCFA. So the first paper was published in the New England Journal of Medicine, and that was the clinical trial. And what we saw was that for the first time, we were able to identify anti-tumor T-cell responses in patients with early stage disease. So these were patients who were treated. So the treatment might have had an effect on our ability to detect these T cells, but this had never been done before. No one had ever identified anti-tumor T cells in the peripheral blood of patients who have such an early stage of disease. And the LCFA funded this work. The next really cool finding, and we published this at the end of 2019, was that not only do you have these anti-tumor T cells, but what this treatment did in these patients was it actually mobilized T cells from the blood into the tumor. So it wasn't necessarily acting on cells that were already in the tumor, but it was causing a systemic effect that resulted in this migration of cells into the tumor where they could kill cancer cells. And the third really exciting thing was that in October, because of the LCFA funded work, I was able to generate enough data to submit my first R01 application. And that goes to study section in about 6 weeks. So hopefully, the LCFA funded work will lead to $1.25 million of funding, if my R01 is funded.
What you hear so clearly in the conversation with Kellie is just how important LCFA's Young Investigator funding is to getting that all-important first chunk of data that can lead to larger grants. For her, it may lead to an additional $1.2 million in funding for an even larger grant. These Young Investigator grants are really the foundation of everything LCFA does.
Yes. And it's also true that Kellie and I get a little bit techie in our conversations.
We've talked about this before.
We have talked. I get chatty with these people because I enjoy these conversations so much. So her grant established that immunotherapy, a medicine that helps the body's own defense system fight the cancer, was effective against the lung cancer tumor. It helped shrink the tumor to make it easier to remove surgically. And, this is incredible, it showed some evidence of preventing a recurrence of lung cancer. This is work that is happening right now, today, and it will hopefully impact the lives of so many people living with lung cancer in the future.
So, stay tuned and we'll be right back. Through the generosity of donors like you, LCFA is able to fund cutting-edge research that will lead to new treatments and protocols with the goal of greater survival rates for lung cancer patients everywhere. We can't do it without you. Consider making a donation by visiting lcfamerica.org and clicking on the donate button. Well, Sarah, another packed podcast today.
You got it.
Our thanks to our guests, LCFA co-founder David Sturges, who shared his experience of living with lung cancer, thoracic radiologist Dr. Denise Aberle, and LCFA Young Investigator Dr. Kellie Smith.
Thanks for listening. Join us next time.
The Hope with Answers Living with Lung Cancer podcast is produced by the Lung Cancer Foundation of America. Find more information online at lcfamerica.org. Thanks for listening.